Hi there, everybody. That's a very bright light, so hopefully you can see and hear me okay. My name's Steve Kell. I'm a GP, still very much a practicing GP. I'm chair of Bassetlaw Clinical Commissioning Group in North Nottinghamshire, and I'm also co-chair of NHS Clinical Commissioners Leadership Group. So I'm just going to tell you, from my perspective, what I really want from our CSU. And particularly with a slant of it's not really what we want, it's what we need. I do have to declare a conflict of interest at the start. Bassetlaw has 112,000 population, quite low running costs, £25 a head, we all have the same. I really need my CSU to work. I really need it to be effective if I'm going to commission and if the CCG is going to commission to the best of our ability. So please take everything I say in a positive slant. We're trying to make the system work. CCGs all over the country are trying to hold the system together at the moment. And CSUs are of huge importance to this. The potential for benefit from CSUs is huge, but I also feel that the risk is significant as well. And that's risk for CSUs themselves, for CCGs, but most importantly for patients whose services we commission. A recent event that we went to in London, an accelerated learning event, spent 2 or 3 days looking at the benefits that could potentially be gained from having a strong commissioning support. We talked about partnership working. We talked about the importance of CSUs in reconfiguration of transformational change, of getting quality information, but most importantly, of sharing knowledge and getting meaningful patient choice. And I have to admit that we're not there yet. I don't think many CSUs, many CCGs would feel that we were. And I think we need to ensure that as we move forward, we really focus on getting that value for services, value for money, and make sure that CCGs and CSUs can be effective as they can. We do have a good relationship locally with our CSU. We've got a large CSU. I think that's really important. I think that's really beneficial in terms of support for people who are embedded in our team. But locally, we've had issues with, as everybody has, with information governance rules. It's April. Information is always pretty scarce in April. We've all reorganised to some extent, particularly the CSU. So locally, I do feel as though we've had a dip in information. So that the knowledge that I have this week on Tuesday at my governing body was probably less than we had 2 months ago. Now, I appreciate this is a dip. The important thing is that we recognise that and move forward and improve, because we can't let things, it's a crucial time. We can't let things stagnate at the moment. We've had lots of discussions locally as CCGs. We work in networks, as many do. We work across South Yorkshire and Bassetlaw. I must admit the CSU isn't at the front of our minds. We're not there yet as CCGs, and I think that's partly because of the way that we've commissioned them. I think we haven't been intelligent enough as customers. I think partly it's because people are focused a bit too much on transaction, on back office functions, and back office tends to mean back of mind when you start getting into the discussions around services, around patient change. So as a clinical leader, we're trying to push that forward to say what's the role of the CSU, what information do we have. If we say we're going to need to reconfigure a hospital, then we need to be clear whether we're doing that on cost basis, whether we're doing that on quality basis, and I'm not sure at the moment that the evidence, the amount of information that we need is really there. And I just want to say a few words about procurement and the CSU strategy. I do have concerns about the pace of change as a CCG leader. We're not yet at a point where I think we've seen a true product from CSUs. I'm really optimistic we can get there together, but I think at the moment I'm concerned how many businesses would genuinely look to externalise before they've established themselves. Can we really procure accurately without knowing what the product is at the end of this? I don't think many businesses would, so I think we need to be really careful together that we don't start using the market for the sake of it, and that we look at what we need to get for our patients and continue to develop each other, because we're developing, CSUs are developing. It's a journey that we need to do together. And a message to NHS England really is that this needs really careful oversight. If we're genuinely going to have choice as CCGs as to which services we commission, which CSUs we need, if CSUs are genuinely going to have choice as to which CCGs they provide services to and which services they provide, then we need to make sure that there aren't gaps emerging in the market, that areas aren't left without commissioning support, that running costs are taken into account, and that we time this right, because if we start a large procurement process at the same time in many areas, CSUs will lose focus, CCGs will lose focus, things like A&E will slip, quality will slip, and that's got to be the priority, that's got to be the thing that we keep at the centre. And there's a tendency as things get more difficult for us to pull things closer to us, for us to gain more control. So we see that from the department, we see that from NHS England, we will see that, I've no doubt, from CCGs moving forwards. I think that's a challenge for CSUs, to show their true value early, to get some quick wins, to make them things that CCGs can't do without. Because particularly the larger CCGs, as things get tighter, money gets tighter, the control from above gets tighter, there'll be a tendency potentially to pull things in, and that will have an effect on our ability to use the market effectively, I think. And my last point is that this needs to feel different from before. We've seen the problems associated with quality, we've seen the Francis report, things haven't been right in the NHS. There is an opportunity here to do things differently, but to make things better. We have new structures, new organisations, lots of people have ideas, there'll be lots of ideas here, but we need to really harness them, share them, and make the commissioning system better than it was before CSUs came along. Thank you.
We'll rock on because I know that time's short. It'll be a huge challenge for me to stand still for those of you who know me in front of a mic. So I'm Lacey Bryant. I'm Director of Corporate Affairs and Partnerships at Milton Keynes CCG. Two really key points in that. It is about partnerships, and as a CCG, we've invested senior level resource in working with our partner CSU, which is GEM, and I'm really pleased that John and I are on the platform together because that emphasises what we're trying to do. I was asked two questions. What do CCGs really want from CSUs, and how should CSUs really develop to meet that need? So 6 points under each, and I'm going to rattle through. So the first thing, what do CCGs really want? Well, we want a bang for the taxpayer's buck. The givens, not the things we want to talk about. The givens are that we need to realise the benefits of at-scale delivery of back office, that we want it to be efficient, that service line leads within the CSU takes responsibility for quality assurance for widgets that are being delivered, because it wastes our energy if we have to divert that. And we need to focus on transformational change. It's a nice mantra, I'll come back to that. We need them to be effective, and that really means, and most of the people, we are all colleagues within the system, really. We've all come from the same NHS family. Even those of us who, like me, had been freelance for 20-odd years before we came back into these roles in the NHS, we're all in the same industry, everyone in this room, and we owe it to the patients out there sitting in A&E now to get this right and to park our egos. So we need to move away from the old style silo working that we know was prevalent pre this round of changes. It's a huge opportunity. And we need to focus on quality. Now, friends here from GEM will know that I believe that quality is about clarity and standards. And we've spent real time working on service specifications, just in case it's really true that we're really going to go out to procure for these services. We want something that's close enough to work with and test. So that's the first thing, bang for the buck. The second thing is alignment with our business priorities. Actually, what I really want my CSU colleagues to do is to feel the heat. I want them to stand on the burning platform beside me, and as they jump into the icy waters, be really incentivized and passionate about taking the opportunity they have. Actually, they've got this vast opportunity to see what's working in other places, to really innovate, to lift and shift. That's the first thing we need to do as we jump in the icy waters, because they're going to close over the health system otherwise. And they need to get the critical products right. And I believe, we don't have to say this. We know what the critical products are. We know it's commissioning intelligence. We know it's contracting. And we really need to stop talking about those things and get them right. But also to understand, as CSUs do, and CCGs also need to really get that when we're talking about customer focus in a strongly cash-strapped system, we've got to really get what can be truly delivered remotely and effectively, and what needs interaction at local level, and what the interdependencies are. So that's the third mantra, customer focus, but it's probably one of the most true things of all. It's about trust. Another mantra is sustainability. Now, we've talked about that. I've just heard John speaking around there really well about the sustainability issues. I really actually think, we are essentially public servants here. Whatever, guys, whoever pays you. We actually need to do much more. We need to understand our influence as contractors, our influence as employers in procurement, because we not only need healthy, sustainable businesses in CSUs, we need healthy, sustainable local economies as well, and we need to take that responsibility seriously. So that's the fourth thing, sustainability. And the fifth thing, support for transformational change. I think there's a book I used to read my kids called None the Wiser. So we know that if we carry on doing the same thing, we'll get the same results. So we all want to do it differently. And from GEM, you just heard John talking about some services that really may help us do that. So solutions for public health, giving us that rationale, and there are one or two knowledge managers in the room, and they'll know that I'm really passionate about having an evidence base for doing stuff. We mustn't do stuff because it makes health professionals feel more cheerful. We must do it because it's the right thing to do. And the right care work, which we're going to be working on with GEM, that's really interesting stuff which may help us genuinely transform. But if we work together and get into a dialogue about what does transformational change look like, and what would the toolkit for that really be, we can start to unpack whether we're talking about contracting or whether we're talking about service redesign to nudge change, or using data to cast light and not heat, or whether we're talking about person-centered care. And thanks to Matthew Harker for a briefing on that last evening. So we need to be moving towards setting up new ways of working, and we need to co-produce. And one of the things that we're really keen on is to work together around defining strategy to make sure that we can get transformational change. And again, the sixth point is that those of you who know me will know that I'm really passionate about developing a learning culture. Now that means real honesty. We have to know what's not working and then really, really praise what is working. We are the new kids on the block in commissioners, and we have much to learn from people around us. On the other hand, let's not suggest that our predecessors got this right. So we need to fail fast, and we're looking for open and honest dialogue. So then I was asked, okay, how should CSUs evolve to meet these needs? And let's rattle out these points. Well, you need to work to your strengths. I mean, one of the things I've said to people here who are CSUs who I spoke to yesterday as I went around the stands was, what are you really good at? Who are you working with? Who are you partnering with? And are you wanting to sell this service to me in a CCG, or to another CSU, or to a customer that might not be here, like primary care in its provider hat? So really strong. So that first thing is work to your strengths. The second thing is really, really invest in collaborative business partnerships. You need, and we need you, to be really, really successful. And to do that, there's a need to understand the nuance of commercial alliance while managing competition between different players on the field. We think it would help you enormously if NHS England could help you work towards your business strategy by helping you understand your future form and really looking at the speed in which you need to reach that. So I don't know whether it's going to be autonomy or social enterprise, but actually I think the really interesting conversations are yet to come and are about risk sharing. Who are you going to share your risks with? I think CSUs already recognise, but maybe not entirely, and CCGs definitely nearly do to recognise that there's a whole range of stuff in which one size fits all is good enough. And we need to have an open dialogue about where that's what we're being offered, because if we don't, we're going to distract energy and resource from really important stuff that needs to be done with good focus. The fifth point is we really want to work with the really brightest of brains. I know John's got 750 staff of whom he's very proud, and there are some really, really bright people there. And actually, we want to get past the widgets and past the transactional stuff to bring the right brains to bear on the issues that we face in Milton Keynes. So we're really pleased to have accepted an invitation from John for his top table to join our top table and start looking at the 5-year strategy with all the uncertainties that inevitably are in that. And that's where I see the added value. And finally, a question really. 18 million acute episodes of care per annum, 305 million consultations in primary care, and with what quality outcomes? So I think there's a question that we need to work on together as to how far CSUs can evolve to transform primary care as part of the bigger picture. I thank you for your time.
Good morning, and thank you. I'm going to be really very quick and say I agree. That's added a lot of value. So let me go back into a serious mode for a second. I can't disagree with anything that we've just heard. I think the really important messages, though, are that CSUs are really looking to develop a long-term partnership arrangement with their customers. More than happy to be held to account, want to be held to account, but what we're really looking to do is to actually move into that how do we add value space, and we do that in part by developing a relationship that's built on trust. So for me, success would be us developing ourselves and moving along on that journey. And within GEM, we currently have 20 CCGs who are absolutely valued customers. But some of them are easier to do business with than others. And what we're inevitably wanting to do is to actually develop the type of relationship where perhaps we're running the marathon together, we're pacing one another, supporting one another, bringing some added value in terms of water before somebody becomes dehydrated. What we're not really looking to do is develop a Tour de France relationship where we're looking to butt up against one another and push one another off our respective bicycles. So from my perspective, CSUs are on a journey where we're about helping, not just in terms of doing the stuff that's always been done in the past, but actually developing that long-term productive relationship where, built on trust, we can actually help health economies to succeed, because we won't succeed if our customers aren't doing well and actually improving services for patients. Thank you.
Thanks. I'm just going to ask, I can't see very well because of the bright light, but if anyone's got any questions they'd like to ask either myself or John or Sue. Sorry, there's a question here and a question over there.
Hi. Yeah, my name's Clive Spindley, and I'm not employed by the NHS. Just like to establish that fact early on. But I'm still passionate about putting patients first. Possibly slightly more passionate about putting patients first than putting the NHS first. I think both the commercial and non-commercial sectors need to work much closer together now. To my question, back to Steve's talk earlier on, he's saying there's a lot of back office transactional data, but not a lot of information. It's not getting turned into the useful information that will help you do your job. I'd just like to ask, I don't know, the CSUs, the CCGs, where, if they feel at all responsible or accountable for the quality of data that is being used to generate the information that they need to run their businesses.
Thank you. Well, if you just pass the microphone to John, we'll take that. Either of you want to pick that up?
So let me try and respond to that question, and thank you for that. I think we have a shared responsibility. So in that regard, I, for example, have one part of GEM where we can provide really fast, accurate and detailed data, but we can do that because we have the ability to process it. But as importantly, the CCGs had agreed with the providers that they provided faster, more complete data extracts, and they'd also agreed with their GP colleagues that the GPs were also going to make their data available as well. And what I can see is that when you actually put all of those different data sources together, you get a much richer and more meaningful offering. So I think the responsibility is certainly ours, but I think there's also a shared responsibility with other parts of the NHS as well.
The only thing I would add to that is one thing that we haven't got around to doing yet is really capturing the amount of real-time, accurate information that is held within practices. So my practice has every letter scanned straight on the same day we receive it. We have a huge amount of information about patients that's real-time, prescribing information, lots of activity and referral information in there. I think we do have responsibility. GPs are working on it, but we do need to capture that as well. John.
Okay, so building on the information theme, it's an invitation rather than a question, which is you talked about partnership, you talked about information governance, and there's a big frustration amongst the whole commissioning community about the changes in the law that have come about, which are kind of restricting access to patient identifiable data for commissioning purposes. So it's an invitation really to commissioning CCG colleagues to work with CSUs, but also with the information centre, so that we actually can get on top of this and we can use the data, as the gentleman said, for the benefit of patients and to create transformational change.
Absolutely. I think we do see that as a key priority. Particularly at a time when locally I'm talking to my GPs weekly about the importance of sharing data and about letting go of records and letting A&E and the hospital system have data in a meaningful way that helps patient care. And yet at the same time with a commissioning hat on, we're struggling to get data that we need around basic activity. So the invitation's accepted, John. Okay. We'll have one more question then, if that's okay.
Thank you very much. My name's Renata Drinkwater and I'm the Chief Exec of Self Management UK. Some of you will know us in our previous guise as the Expert Patients Programme. And I guess my challenge to you is, the mantra patients first has come through quite strongly, but I think the challenge is how are you actually going to involve patients, whether it's within CSUs or CCGs, in terms of actually having some real influence and not just lip service paid to involvement in commissioning decisions. Thank you.
Sue, do you want to?
Is that on? Yeah. We're really passionate about that in Milton Keynes. We've been working for a very long time. It requires a certain amount of infrastructure, so we've got patient participation groups at most of our practices now, and they're working up through a patient congress. Many of those are working, of course, around issues into GPs as providers, but nevertheless, there's a huge channel of opportunity there to be taking back feedback and the patient's voice around experience of those services that we commission and which member practices are responsible for commissioning. So that's one stream. We work very closely with Health+, as we have done for a very long time, and we've developed a thing called a Public Advisory Forum, where we're bringing together channels, a small group, to really take an overview and really G up, give assurance, but G up our approaches to public and patient engagement. We're an average size CCG. We serve a population of 260,000. I did an audit both of clinical engagement beyond board members and public and patient engagement beyond board members in decision-making arena, and we've got 22 members of the public and patients involved in commissioning decision-making groups within our CCG at the moment. We want to put some training behind that, and the people there are not representative. They are not giving a single voice. They are there to help us reach back into the community and into every sector of the community for which that particular commissioning decision is pertinent and at a proportionate level. So we are taking that very seriously, but always willing to learn.
The two things stand out for me, and we talk about this a lot in my CCG in Bassetlaw. One is, it sounds obvious, but always tell the truth. If things are difficult, then we need to stand up and say things are difficult. If there's an issue, we need to say there's an issue with care, and that enables patients, I think, to have a greater say in their local populations, their local services. The second thing is be really transparent. So the information that we have, we share, and I think that's, again, it's a journey we're moving on, but I think the more information, the more meaningful stuff that patients can access through CSUs and CCGs, then that forces us to have difficult conversations sometimes, and that can only be beneficial. So I apologise for the late start. I apologise for the noise, the rest of the arena, but hopefully people could hear us okay. Thank you very much.